things. So it's real important to do one eye at a time. But any changes on that, that is a good indication you need to get in and see your doctor and let him make sure you're not slipping into wet macular degeneration, because there could have been a leak or a hemorrhage or something like that. As you notice, the gray hair, this is pre-teenage years of my children, and we'll see the gray progresses as we go. The instrument you can see on my head when I got my ninja outfit on, that was developed by Dr. Tolentino's father, Dr. Felipe Tolentino, in their labs up there. We use that every day. It's in the Smithsonian now. So, I mean, that's just one of the contributions that that Boston group gave us that we use on a daily basis. The slit lamp is basically a vertical microscope. So when we have you sitting down in the chair and we push that thing up in front of your face, it's basically a microscope that we can see the details of the front of your eye. We can examine the front being the cornea, the clear part in the front. Then we go back and we look at that little space in the front and see if there's inflammation or cells. We get back to the iris, that's the colored part. The light eyes, as you'll find out, are more prone to macular degeneration, so that right immediately is telling us something as far as risk factors and how prone you might be to the macular degeneration. And then we have some high-powered magnification. We add to that and some handheld lenses that allow us to then focus into the back of the eye. And that's what we're doing when we have you sitting down up front. That's one of Mark's illustrations. Michael, you will notice that the image in the lens is inverted properly. Okay, and so this is the kind of work that Mark's doing to help us, you know, explain what we're doing and educate people to the inside of their eye, which is a pretty fascinating little area that we're talking about. So these different lenses we have allow us to see at various magnifications all of the structures in the back of the eye, and that's why they're so bright. There's no lights on, well, so to speak, inside the eye. We know there's lights on elsewhere. But we have to use a pretty bright light to really get the reflection of light back, that we can see the detail of the structures. We know it's uncomfortable. We try to temper that. Some eyes are just so much more light sensitive than others. We need to be sensitive to that. We need to adjust the power of our light, and not just, every eye is not the same. And some of these bright lights are very painful to people. So we can work in a little dimmer environment, but sometimes you have to have the light to see what's going on, the pathology and that thing. So that gets us to the back of the eye, the optic nerve, where we're looking for glaucoma. That can be detected looking at the shape and contour of the nerve. Can often distinguish a healthy nerve from a nerve that may be in trouble. And so we also look at the vitreous, the floaters that you guys get bothered by, some much worse than others. That's the vitreous gel in the eye, and we look at that as we're getting to the back of the eye. We're looking for hemorrhages, if that gel has a separation away from the retina. So those types of things come right at us at the exam. Then we get to the retina, looking for, if you're diabetic, looking for any early vascular changes, little bleeds, blood vessels, that type of thing. And the macular degeneration, other macular pathologies that may not be macular degeneration, macular puckers. Those are little wrinkly membranes on the surface of the macula. They can give you distortion in your vision. Some people have a macular pucker that, if it gets worse, it can be surgically peeled and can actually correct the problem. Some people have a macular pucker on top of macular degeneration. Then it's always a little harder to assess if we're going to peel off that pucker. Is it a 60-40 macular pucker to macular degeneration, or are we going to end up peeling a pucker and the macular degeneration is a little worse than we're anticipating? That's always a little bit of a hard call, but we try to fix what we can fix and support and maintain the rest in the hopes that your body will do the rest of the healing. And if we can put things back in place where your body will take over, it usually is always trying to heal and mend. And so that's a lot, in my mind, what we're trying to do is just get the body involved in the healing process. We also look in, again, as I mentioned, that peripheral retina, looking for retinal tears and anything that might show a weakened retina that could lead to retinal detachment or something, again, that could come in and affect the peripheral vision and create, other problems. Michael's gone over all the things with the drusen. I did take some exception to all the garbage man analogies. I was a garbage man, drove a garbage truck. They called it Deupree. Yeah, they said dated Deupree, got $1.65 and all he could eat. So I'm a little sensitive about that, but I think you were, really pretty good about it. So the wet macular degeneration, as we talked about, we're looking at our exam and going right at these little hemorrhages, anything that shows swelling, fluid. We see that well on our exam, but we get into other areas, and now the newer technologies, some things are very obvious on the exam. Other things are incredibly subtle. And some of these new scanning technologies and things have allowed us to see things and understand them that we kind of knew were there before, but we didn't really know at what level in the retina, where they were occurring. So we're getting so much more information off these technologies. They become easier to utilize for the patient, and we're going to cover those. The fluorescein angiogram has been around for a long time, probably I think the 70s or 60s, probably somewhere in there. A couple of medical students were experimenting, injecting dyes and then taking photographs, and they came up with a great technology and technique that's allowed us to very safely image the back of the eye and look at the vasculature of the retina down to very detailed capillaries. So when you get this dye, all you have to remember, the green dye, it's the same dye they use to dye the fountains on St. Patty's Day, okay? And that all washes clear. So it's a water-based dye. It's not going to leave your water fountain or anything else you got going on permanently green. But it does travel through the circulation from the time it's injected in your arm. It'll actually be through your circulation into your retina in 8 to 12 seconds. And I mean, that's how fast the blood flow is moving through your body. Once it gets up there, the photographer, the angiographer and photographer, he's first going to start out that exam with a couple photographs, the color photographs. That's a nice record of what your retinas look like today. You can see on the pictures up there, and we're going to see some little bigger pictures as we go. The next phase of that is what we call the red-free photographs, and that's just utilization of a filter that blocks out the red light and allows us to see a higher detail of the structures and the anatomy, sometimes the nerve fiber layer. And so those are just really high-resolution photographs that, again, we kind of use those as documentation and helps us see subtle changes in the retina that are sometimes easy to miss with the naked eye. Then we give you the shot of dye. And he starts taking pictures. On that top right, you can see where it's pretty dark. Well, the dye is just barely hitting the inside of the eye. Excuse me. Then serially after that, he starts taking these photographs to try to catch the progression of the dye as it comes up in through your carotid arteries and up into the ophthalmic arteries into the eye. And then it first starts flashing in the choroid, which is that deep layer. And we want you to, on the next scanning pictures, think in layers is what Michael was showing you, and all the way through this. Think of the layers of the retina. It's like a 10-layer Subway sandwich, but I mean, it's got all these layers in it, and then under that retina is another vascular layer that's then divided by a membrane, like the visqueen that in your garden to stop the weeds from coming through. There's a little membrane between the blood vessels on the outside of your wall of your eye and then the retina with its 10 layers on the inside. So if you think in terms of layers back there, you'll understand where different problems occur and how the treatment varies. But the angiogram then picks up and goes from the choroid into the arterial section. So the arteries take the blood in, then it goes out and flushes through all the little capillaries throughout the retina, which basically is kind of the business end. That's where all the exchange of nutrients, oxygen, and all the debris gets picked up and brought back out of the eye. And so the angiogram flushes out through the arterial phase, goes through the little capillaries. The photographer is snapping photographs with a real bright flash and filters in there that allow us to see the fluorescence of the dye. And then we get into these later stages. So what you see here is a little abnormal neovascular membrane, which is wet AMD. It starts to light up and it gets brighter, and then through the later phases it gets just a little fuzzier. And so it's not a real terribly active vascular membrane, but we see that it does have a little bit of staining in the dye and that kind of thing. So it helps us kind of know where you're at. So we differentiate between wet and dry with this test is kind of the standard. And you can see again, if you look at that top right picture, it's kind of a lacy little, we call them, it could be like a sea frond, you know, it's a very delicate structure. And those are abnormal capillaries that have grown up underneath the retina and kind of burst from that deep, deep layer up towards the surface under the retina. And then if you look at the bottom right, you can see how the dye is starting to leak out. That's the white part, and it gets bigger and spread out, and that's how we know it's an active leak. So it used to be they'd laser that, and they create this big black scotoma, which I thought, well, never mind, I won't go into that, but I never liked that idea. Then there was subretinal surgery where we try to go in and pluck out these little membranes, and that was another approach. Now we have these injectables, which sounds bad, but we actually can do it in a very painless fashion, and we'll be going over that with you later. But these injectables will go in and cause reversal of those little blood vessel membranes, and that's the miracle of the new drug. Those little blood vessels dry up, go away, and hopefully don't leave a big scar, and we end up with better vision and significantly better than we were doing 7 years ago. So I know guys that have come out of retirement because they got so excited about the new drugs and called in all their golfing buddies that had macular degeneration and started shooting them with the new drugs and getting them seeing better, and actually worked another 3 years before he retired again. So that was a local retina specialist. So with these testing, we can decide, is this active? Does it need treatment? You know, is it stable? So these things help us gauge your problem, your disease. I think it's always a good idea, you know, to look at both eyes every time, because I can't tell you the number of times where you got one eye that's starting to be active, and you go, well, let's get an angiogram or make sure we look at the other eye, and all of a sudden you pick up another little active area. Because if one eye acts up, it doesn't mean you're definitely going to get wet macular degeneration in the other eye, but it does occur, and so we have to be even more acutely aware of any change, because that now is probably your better eye, and so keeping your good eye out of trouble, so not dilating that, not every time necessarily, but you watching your Amsler grids, reporting to us any vision changes, and realize, you know, we're going to dilate that eye and take a look, because that's your main eye, that's your shooting eye, your driving eye, and everything else at that point a lot of times. We kind of covered that. You can see the angiogram kind of developing on the screen. That's the late end, but it starts, now let's just watch that one more time. I think I can get it to go again. Here it comes, and you see that little frond vessel, and then the dye is kind of leaking out. And that's leakage is occurring under the retina. The overlying retina, in general, is kind of in pretty good shape at that point. It doesn't like that leakage. The inflammation is, to me, the common denominator of most diseases, and so treating that inflammation in various ways through nutrition and so on, as we'll bring out later. I see Rod Horton over there. I think so. Anyway, he does a lot of this kind of stuff. And then there's different types of membranes. Some are those really classic defined ones that I told you about, and some are just more diffuse. It's kind of an ooze, and the leakage is much more spread out. These can be a little tougher in a lot of ways, but again, we're getting better at it with the treatments there. There's other things we see, the PED, which is kind of a blister in one of the deeper levels. That stands for pigment epithelial detachment. So of course we always say PED because it's a mouthful, but you know, those are the things that when your doctor is discussing with you, I think now you're going to have a much better idea, especially by